So let's start with the left ventricular systolic assessment. Um, so out of all of these views, the highest yield are going to be your first three. These are the ones that you certainly want to focus on when you are assessing the LV. So your parasternal long axis, your short axis, and your apical views. Again, your subcausal views in patients where you cannot access the chest very easily, you can get a complete echo from your subcausal views, but that does require some proficiency with POCUS to be able to get those views. So, we normally, when we talk about systolic function, we automatically go to LV ejection fraction. And just as a reminder, that is a calculation of volumes, right? So we're looking at the stroke volume. So the LV end diastolic volume minus the LV end systolic volume. And we're dividing that by the LV end diastolic volume. So, we use this as a surrogate for systolic function, but we know we know that this is not always the most accurate idea of what's going on with systolic function. So even though we use it as a surrogate to be synonymous with systolic function, you can have a low output state in someone with a normal ejection fraction, and you can have a normal output state with someone with a low ejection fraction. So I just want to challenge this concept that just because you see the ejection fraction being normal or actually even vigorous, or if you see the ejection fraction being low, it doesn't necessarily mean that this is a low output or a high output state. We'll discuss this a little bit further. The limitations of using LV ejection fraction as a surrogate for systolic function is that it really is dependent on loading conditions. So in patients who are very hypovolemic, for instance, right, they have some sort of an acute bleed or they're very dehydrated, their ejection fraction is going to look a lot better. Whereas if you have someone in a hypertensive crisis or they're very volume overloaded, then the ejection fraction is going to look a lot worse, whereas it may not be a reflection of their actual systolic function. It's also important to note where we are when we look at LV ejection fraction. Even though we have quantitative methods where we, trace out the end diastolic volumes and the end systolic volumes, this does have some limitations. So most of the time we're looking at visual assessment, and there is quite a bit of inter-reader variability. And again, because we're looking at endocardial excursion, how is the endocardium moving in systole and diastole? When the patient is tachycardic, it becomes very difficult to discern that because it decreases your diastolic filling time. And so your visual estimation tends to see the ejection fraction as being less than what it actually is if the patient was not tachycardic. So as long as we understand that these are the limitations, it is what we use most frequently when we are assessing the LV systolic function, but it does have its limitations. So I did want to take some time to take a look at what does a normal ejection fraction look like. And this is, the parasternal long axis view. So you have the pericardium over here, the RV over here, the aorta over here, the aortic valve. And this is your LV with the anteroseptal and infralateral walls with the LV cavity. Your mitral valve is here and your left atrium is here. Now, even though you're only seeing the anteroseptum and the infralateral walls over here from the basal to midsections, it looks like it has a pretty good squeeze. This is your short axis view. So again, we are just changing the angle of the marker so that it is at 2 o'clock. And if you see just sort of homogeneously, it looks like the LV is squeezing nicely with all of the walls in this midsection. And this is your apical 4-chamber view. So again, you're going to go to the 5th intercostal space. You're going to be between 2 and 3 o'clock with your marker. And here you see the LV, which is squeezing actually quite vigorously. Your mitral valve is over here. Your left atrium is over here. Your right ventricle is over here and your right atrium is over here. So again, just visually assessing this, this does look normal to vigorous. And actually just pull these images from patients who are in the ICU right now. I wanted to be very real about the quality of the studies that we tend to get. We should be able to still discern quite a bit from these studies. Now, in a very different scenario, this is somebody with a very low ejection fraction. This is somebody who actually is in the CCU right now. So same views that we just saw, parasternal long axis. But if you focus on the LV, it is dilated. It is globally down, which I'll show you on some of the additional views. But this should look very different to you than the last view that we just took a look at. Here's your short axis view. Again, globally down. It looks like maybe the anterior septum is moving less than everything else, but this is an ejection fraction that is very reduced. And this is your parasternal long axis views. So same thing here. You're seeing that the LV is globally reduced. And I think this was given an ejection fraction of 15 to 20%. So say that last patient, the last echo that we saw, that's the echo that you're getting on this 56-year-old woman who's hypotensive. Does that mean that this is cardiogenic shock? Now, certainly the fact that she has such a low ejection fraction should raise concern, but ejection fraction, as I had just mentioned, does not necessarily mean cardiac output. So I just want to be, to delve a little bit more into, can we get more from echo than just ejection fraction to help us with clinical decision making?